تمام. بسم الله الرحمن الرحيم. مساء الخير على حضراتكم. قبل ما ابتدي طبعا لازم اشكر الاخ والصديق والزميل العزيز الاستاذ الدكتور اسامه حسين, President of Port-Said Neonatology Society and the President of the Conference, على دعوتي. سعيده ومبسوطه جدا بوجودي مع حضراتكم. حقيقي اتشرفت, وفعلا انا بحب اشارك جدا, وكلنا مش انا بس, كلنا بنحب نشارك في مؤتمرات الاستاذ الدكتور اسامه حسين. تنظيم متقن جدا, بياخد باله من كل التفاصيل, thinking outside the box, very rich scientific content. فالحقيقه حاجه رائعه. ببارك له جدا على النجاح بتاع النهارده, وان شاء الله النجاح مستمر يا رب الفتره اللي جايه وكل سنه. بشكر حضرتك جدا يا دكتور اسامه. برضو لما فكرت انا والدكتور اسامه, طيب ده مؤتمر نيوناتولوجي واحنا ناس بتوع اندوكراينولوجي, طب نعمل ايه؟ نعمل نيوناتال اندوكراينولوجي سيشن, ومن هنا جت الفكره بتاعه السيشن بتاعتنا. يسعدني وجود اثنين الحقيقه يعني اخواتي الصغيرين, ويعني ناس حقيقي نجوم صاعده في مجال البيدياتريك اندوكراينولوجي. دكتوره شيماء السيد, مدرس طب الاطفال والسكر والغدد الصماء جامعه اسكندريه, والدكتوره منى كارم, مدرس طب الاطفال والسكر والغدد الصماء جامعه قناه السويس. هيشاركوني السيشن ده. مبسوطه جدا انهم معايا. اوعدكم بمحاضرتين قويتين جدا جدا. انا متاكده انكم هتنبسطوا جدا ان شاء الله من الكيس برزنتيشنز. احنا السكادجول بتاعنا في السيشن, هبدا كلامي انا هتكلم عن النيوناتال هايبوغلايسيميا جنرال ريفيو. بعد كده الدكتوره منى كارم هتعرض لنا challenging case of neonatal hypoglycemia, وبعد كده الدكتوره شيماء هتعرض لنا challenging case of neonatal hypercalcemia. اتمنى يا رب ان السيشن يعجب حضراتكم. ما تنسوش تكتبوا لنا الاسئله بتاعت حضراتكم في الكيو اند اي بوكس. ان شاء الله بعد ما الثلاث محاضرات يخلصوا هنجمع كل الاسئله واحنا قاعدين معاكم. خلاص احنا اخر سيشن, هنجاوب على كل الاسئله اللي حضراتكم عايزينها. يا رب الويبينار يكون يوسفل لحضراتكم. هتكلم عن النيوناتال hypoglycemia, and this is when time matters. Of course, hypoglycemia is a very common metabolic problem. It's a biochemical finding and not a diagnosis by itself. Interpretation of blood glucose in the context of clinical and lab picture is very important. Don't forget to look for the cause of hypoglycemia. And finally, remember that time matters because you are saving a neonatal brain. If we look at the glucose physiology, glucose in the bloodstream is transported to the body cells where it is used to provide energy for cellular processes. And in the muscles, it is stored in the form of glycogen, which is needed to provide energy for movement, and some is stored as glycogen until needed in other body parts of the body. The maintenance of normal blood glucose is not easy. It needs a perfect balance. And the sources of blood glucose come mostly from the diet by ingestion and absorption. Glycogenolysis, which is the main source during early fasting, 12 to 18 hours. And when the fasting exceeds 18 hours, the main source during prolonged starvation is gluconeogenesis. And then glucose goes to the blood, and it is then used by oxidation or conversion to lipids, which is the lipogenesis, or being stored again for glycogenesis to be reused again. And so the regulation of blood glucose level needs a perfect balance, as you see. When the blood glucose rises, insulin, which is the only glucose lowering hormone, takes the upper hand in order to decrease the blood sugar level. When the blood glucose drops, there is a list of counter-regulatory hormones like glucagon, epinephrine, norepinephrine, cortisol, growth hormone, and thyroxine, which act on the other side in order to increase the blood glucose level, causing normalization of the blood sugar back to normal. So what are the biochemical changes that occur during fasting? First, remember that pancreatic beta cells are extremely sensitive to the blood glucose concentration. Insulin secretion is switched off when glucose concentration reaches around 4 millimoles per liter. And then there is an increase in the glucagon and adrenaline, and finally increase in the serum cortisol and growth hormone. So this is the sequence of events when the body is exposed to fasting or hypoglycemia. At birth, the healthy term newborn must adapt to an independent existence by adequate glycogen stores, glycogenolysis, gluconeogenesis, lipogenesis, ketogenesis, and of course, the counter-regulatory hormones. A very important point is that a normal infant at term shows immediate postnatal fall in the blood glucose during the first 24 hours, from values close to maternal levels to around 45 milligrams per deciliter. So this could happen in normal neonates. So what is the definition of neonatal hypoglycemia? This is when the blood glucose is less than 30 milligrams per deciliter in the first 24 hours or less than 45 milligrams per deciliter thereafter. After 72 hours of age, all newborns should maintain a blood sugar above 70 milligrams per deciliter. Again, remember that neonatal hypoglycemia is the most common metabolic disorder in neonates. As you see here, there's a very long list of causes of neonatal hypoglycemia, either due to poor glucose production in terms of prematurity, SGA, maternal beta blockers, or inborn errors of metabolism. Could be due to increased glucose demands in case of sepsis, hypothermia, intrapartum hypoxia, RH disease, or polycythemia. Could be due to hyperinsulinism, like infant of diabetic mother, congenital hyperinsulinism, or the syndrome of Beckwith-Whitman. Or finally, it could be due to endocrine disorders, namely adrenal insufficiency, hypothyroidism, growth hormone deficiency, or panhypopituitarism. Fortunately, most of the cases of neonatal hypoglycemia are transient and resolve within few days due to 2 to several months. It could be either maternal or perinatal stress. Maternal could be due to transient hyperinsulinism, like infant of diabetic mother, intrapartum glucose infusion, or drugs. For the perinatal, stress could be SGA, preterm, asphyxia, RH incompatibility, sepsis, hyperviscosity, or hypothermia. So when you face a neonate like this with jitterness, irritability, high-pitched cry, hypotonia, lethargy, poor feeding, hypothermia, seizures, tachypnea, apnea, cyanosis, or cardiac arrest. If you look at these symptoms, you can see clearly that these are non-specific manifestations which can occur in any sick neonate. So remember to measure blood sugar and electrolytes in any neonate who is not doing well. Now let's start with this case. This is a 2-day-old neonate. He was born preterm, SGA 1.2 kilos, respiratory distress. The mother is not diabetic. The parents are not consanguineous. The baby was asymptomatic, but the neonatologist screened the blood sugar. It was found to be 42 milligrams per deciliter. The CBC, CRP, and electrolytes all were normal. So how to deal with such a neonate? When managing asymptomatic hypoglycemia in high-risk newborn, first of all, if the blood sugar is less than 25 milligrams per deciliter, follow the protocol of symptomatic hypoglycemia. If the blood sugar ranges from 25 to 45 milligrams per deciliter, try oral feeding and monitor the blood sugar after 30 to 60 minutes. If still less than 45, follow the protocol of symptomatic hypoglycemia. If exceeding 45, monitor the blood sugar every 6 to 8 hours and stop after 48 hours, and usually the baby will recover. So the conclusions here are SGA, maternal toxemia, and birth asphyxia are risk factors for neonatal hypoglycemia. If asymptomatic hypoglycemia and the blood glucose is less than 25 milligrams per deciliter, follow the protocol of symptomatic hypoglycemia. If asymptomatic and the blood sugar ranges from 25 to 45 milligrams per deciliter, give oral feeding and reassess. The mechanism of hyperinsulinism in SGA infants is not fully understood. Hypoglycemia is usually transient and resolves spontaneously within few days. And sometimes with SGA, hypoglycemia can last for a few months, and some patients require diazoxide. Another different story is a 20-day-old newborn. He was born full term by cesarean section, developed neonatal jaundice. The mother is not diabetic. the birth weight and length are normal. The baby developed recurrent generalized tonic-clonic convulsions with lethargy, poor feeding, and micropenis with otherwise normal genital appearance. Also, the baby has got depressed nasal bridge, as you see here. So in such a case, a baby who is convulsing and not doing well, the suggested preliminary labs, as you see here, all were completely normal, apart from indirect hyperbilirubinemia and a very low random blood sugar, as you see. So the baby has got symptomatic neonatal hypoglycemia. So what to do with such a baby? When you face a neonate with symptomatic neonatal hypoglycemia, we give IV bolus of glucose 10%, 2 cc per kg, and then glucose 10% infusion at a rate of 6 to 8 milligram per kg per minute. And then you check the blood glucose after 30 minutes until euglycemic, and then 6 hourly. When the blood glucose exceeds 45 milligrams per deciliter and the baby is stable on IV fluids for 24 hours, you taper the infusion rate by 2 milligrams per kg per minute every 6 hours and try to introduce oral feeds. And then you stop the IV fluids when the rate is 4 milligrams per kg per minute. What if the blood glucose is less than 45 milligrams per deciliter? Repeat the bolus and keep increasing the glucose infusion rate. And if you reach a rate of more than 15 milligrams per kg per minute, you must look for the cause. And the question here, how could we look for the cause in a case like this? If you have a baby like this who is hypoglycemic, not responding to usual lines of treatment, and you keep giving glucose IV and the baby is not responding, what is the next step in such a neonate? The next step is to withdraw a critical blood sample. And this is very important to identify the cause. In the urine, you look for the ketones, organic acids, and reducing substance. In the blood, you measure the blood glucose, insulin, C-peptide, growth hormone, cortisol, thyroid functions, beta-hydroxybutyrate, free fatty acids, and ammonia. And putting these together, you can diagnose and treat the cause of hypoglycemia according to what you have found. So, if you have a neonate with persistent hypoglycemia, and by persistent, I mean more than 1 week not responding to usual lines of treatment, it's either non-ketotic or ketotic. If non-ketotic, you measure the free fatty acids. If high, this is a fatty acid oxidation defect. If low, think of hyperinsulinism. What if ketotic and the baby is acidotic with hyperammonemia? If the answer is yes, this is organic acidemias managed by geneticists. What if not? Look for hepatomegaly. No hepatomegaly, this is an endocrine disease, could be cortisol, growth hormone, or thyroid, and this will be revealed by results of the critical sample. If yes, the baby has got hepatomegaly, measure serum lactate. If high, look for gluconeogenesis defects. If normal, measure urine reducing substance, which if positive, you will go for galactosemia and hereditary lactose intolerance. If negative, you are left with glycogen storage disease. And of course, there's a long list of investigations to diagnose glycogen storage disease and its type, and this is diagnosed by the hepatologist. So let's go back to our baby. A very low fasting blood glucose. The beta-hydroxybutyrate was found to be ketotic. This is ketotic hypoglycemia. The insulin is normal. Other than that, everything was completely normal. And look at the growth hormone. It was found to be very low in the critical sample. And so the diagnosis here is congenital growth hormone deficiency. The clue in neonates is hypoglycemia and or micropenis and not short stature. So the conclusions here are, the clue for diagnosing growth hormone deficiency in neonates is micropenis and or hypoglycemia. Congenital growth hormone deficiency is diagnosed by critical sample of hypoglycemia and not by growth hormone provocation test. Remember to exclude congenital growth hormone deficiency as a cause of neonatal hypoglycemia. And with congenital growth hormone deficiency, always exclude other pituitary hormone defects and perform MRI celatosica to exclude other anomalies. Now, this is a 1-month-old baby with a totally different story. The baby was born full term. He was referred as a male with bilateral undescended testes. The parents are first cousins. If you look at the photo, you can clearly see that the genitalia are pigmented. There is a phallus 3.5 centimeters, a single opening at the tip of the phallus, bilateral impalpable gonads, and the baby arrived shocked, dehydrated, with disturbed level of consciousness. First, we should deal with urgent life-saving investigations before going to the diagnosis. And here, the baby was found to have a very low random blood sugar, very low serum sodium, high potassium, and putting these together, we must think of adrenal insufficiency. The cortisol was found to be very low, the ACTH is high, and the aldosterone is low. So this is a case of hypoglycemia due to adrenal insufficiency associated with genital anomaly. And because of this, we measured 17-hydroxyprogesterone, which was found to be very high as well. And the karyotype came as a 46XX with uterus and ovaries seen by ultrasound. So the final diagnosis here is female with classic salt-losing congenital adrenal hyperplasia, in spite of the fact that the case was referred as a boy with bilateral undescended testes. So this is very important. Now, the conclusions from this case are, if you have a triad of hypoglycemia, hyponatremia, and hyperkalemia, think of adrenal insufficiency. Hypoglycemia is corrected after the start of hydrocortisone. Males with congenital adrenal hyperplasia present with normal genitalia, and later on, most of them develop precocious puberty. Females with congenital adrenal hyperplasia present with various degrees of genital ambiguity, ranging from mild clitoromegaly up to complete male phenotype with undescended testes. And therefore, if you have a baby with bilateral undescended testes, it's very important to apply the workup of disorders of sex development or ambiguous genitalia. If you have a baby with unilateral undescended testes, no problem. It's the usual thing. You can refer to surgery or give treatment. Another different story is a one-day-old neonate who presented with generalized tonic-clonic convulsions. The baby was lethargic with poor feeding, cyanosis during feeding. He was born by cesarean section at 36 weeks with a large birth weight, 4.7 kilos. He was admitted at neonatal ICU for RDS and convulsions. The mother has uncontrolled diabetes, very high hemoglobin A1C, as you see, and she is on insulin. Maternal grandpa has got type 2 diabetes, and the parents are not consanguineous. If you see the baby, it's clear the baby is large for gestational age, puffy, plethoric, jaundiced, tachycardic, tachypnic, RDS, cold extremities, hypotonia, and lethargy. This is the typical features of infant of diabetic mother. And here, what are the suggested labs that we need to do in such an infant? We did a CBC, hemoglobin was high, and the hematocrit was high. And look at the random blood sugar, it was very low. And here you can see very low magnesium, low calcium, and the serum phosphorus is high with a very low parathyroid hormone. So this is functional hypoparathyroidism. Here you can see indirect hyperbilirubinemia, and these are the typical metabolic errors in infant of diabetic mother. Also, the baby was found to have cardiomegaly and pulmonary congestion. A VSD was seen on echo screening, and right-sided renal agenesis was seen by ultrasound as well. So, maternal diabetes predisposes to fetal hyperinsulinemia, which causes neonatal hypoglycemia. Also, B-cell hyperplasia produces a macrosomic infant liable to birth trauma and cardiac hypertrophy. Also, excess fetal metabolism causes relative hypoxia with polycythemia and hyperbilirubinemia. Decreased lung maturation predisposes to RDS, and decreased parathyroid maturation predisposes to functional hypoparathyroidism with hypocalcemia and hypomagnesemia. So the conclusions from this baby are: screening for hypoglycemia is important in infant of diabetic mother, even if asymptomatic. Hypoglycemia is transient in infant of diabetic mother due to transient hyperinsulinism. Screening for cardiac and renal anomalies is very important. Screening for and treatment of associated metabolic problems like hypoparathyroidism, indirect hyperbilirubinemia, and polycythemia is very important. Another spectrum is this 2-day-old female newborn who presented with recurrent generalized clonic convulsions at the fed and fasting states. She developed apnea, cyanosis, lethargy, and the parents are first cousins. They had a male sibling who died due to neonatal convulsions in the first week of life. At this point, the cause was not recognized. The mother is not diabetic, but the baby was born large, 4.5 kilos. As you see, no dysmorphic features or gross congenital anomalies were seen in the baby. If you look at the metabolic profile, everything was normal apart from a very low random blood sugar, as you see here. Again, hypoglycemia persisted despite continuous IV glucose infusion rate, and we kept increasing glucose infusion rate exceeding 15 milligrams per kg per minute, in addition to 2 hourly feeds and added corn starch, but the baby did not respond. And so we decided to withdraw the critical sample. The ketones were negative, so this is non-ketotic hypoglycemia. The fasting blood sugar is low, the fasting plasma insulin is very high, the insulin glucose ratio is high, and the rest of the things were completely normal. We were also able to exclude all inborn errors of metabolism. As you see, looking at the data here, everything was completely normal. So what is your diagnosis here? This is a typical case of congenital hyperinsulinism, and this will be discussed in details by Mona. So when to suspect congenital hyperinsulinism? If you have a neonate with persistent hypoglycemia not responding to usual lines of treatment with a glucose infusion rate exceeding 15 milligrams per kg per minute, think of congenital hyperinsulinism. As you see here on the right side, it could be either focal or generalized. And how to differentiate, we use the PET scan. And sometimes it's even ectopic outside the pancreas, which makes things worse and more difficult to diagnose. So 18F-DOPA PET scan is used to differentiate from focal and diffuse congenital hyperinsulinism. So what is the mechanism of insulin secretion from beta cells? Imagine that this is the beta cell of the pancreas. Glucose is transported by GLUT2 transporter into the pancreatic B cell. By glucokinase, it forms glucose 6-phosphate. By glycolysis, it forms pyruvate, which enters the Krebs cycle. And GDH is stimulated by leucine, increasing ATP production, and this stimulates closure of potassium ATP channel. And depolarization of the membrane occurs, causing opening of voltage-dependent calcium channel with influx of calcium, increasing the intracellular calcium inside the cell, and this causes secretory granules to fuse with the plasma membrane, resulting in insulin secretion. Look how complicated the mechanism is. And based on this, there could be mutations causing congenital hyperinsulinism according to which part was affected. It could be due to inactivating mutations in SER1 or KER6.2, or activating mutation in glucokinase, or activating mutation in monocarboxylate transportase 1, or stimulatory in GDH, or unclear mechanism like inhibitory mutations in HNF4 alpha. A lot of other mutations could be seen. But most important is to do genetic testing, because there is a genetic makeup for focal lesions, which will be easy to diagnose by the PET scan, and here the treatment will differ a lot. If you look at the potassium ATP channel, there are 2 subunits of potassium ATP channel, one encoded by KCNJ11 gene and the other by ABCC8 gene. And here you can see that it's either autosomal dominant or recessive. It's the most common cause of hyperinsulinism, and most of the cases are not responding to diazoxide. So when you face a case of persistent congenital hyperinsulinism, try medical treatment for 1 month. And then, if the patient responds, reassess and discharge. If the patient is not responding, you have to do genetic analysis to target you either towards focal or generalized. And if you need to differentiate focal from diffuse congenital hyperinsulinism, you have to go for the PET scan. If it proves to be focal, this is very easy. Go for focal lesionectomy. But if diffuse, evaluate the medical therapies. If the patient is responding, this is mild, continue in medical treatment. Sometimes patients do not respond in severe cases, and in such a case, we go for subtotal pancreatectomy. Regarding the drug therapy for diffuse congenital hyperinsulinism, either diazoxide, which opens potassium ATP channel, or nifedipine, which is a calcium channel blocker, or here you can see the octreotide, which inhibits insulin secretion from the beta cell and inhibits calcium entry into the cell, and a lot of medications. My last case is a 1-week-old neonate whose mother is not diabetic, but the baby was born macrosomic, a very large birth weight, 4.9. He developed generalized tonic convulsions. The baby was jittery, macroglossic, hemihypertrophy. He's got umbilical hernia. And as you see in the photo, there are ear creases and pits. And what was characteristic, the random blood sugar kept very low, not responding to usual lines of treatment. So what is the next step? As usual, a critical sample was done. The ketones were negative, the fasting blood sugar very low, the fasting insulin and insulin glucose ratio was very high, and the rest of the things were fine. So if you put these lab data with the appearance of this baby, what is your diagnosis? This is a typical case of Beckwith-Widman syndrome. And what are the features of Beckwith-Widman? Here they have congenital hyperinsulinism in about 50% of the cases. It's usually transient, but sometimes it is very severe. They have macroglossia, omphalocele, hemihypertrophy, lateralized growth, and they are liable to tumors like Wilms tumors, hepatoblastoma, gonadoblastoma, and neuroblastoma. And it's very important to start screening for these tumors at the age of 6 years onward, every 6 months. And so the conclusions here are: suspect congenital hyperinsulinism if hypoglycemia requiring high glucose infusion rate more than 50 milligrams per kg per minute. Congenital hyperinsulinism is confirmed by critical sample if hypoglycemia plus hyperinsulinemia. A TF-DOPA PET scan is the current gold standard method to differentiate focal from diffuse congenital hyperinsulinism. Genetic testing allows you to decide who will need the DOPA PET scan. Some mutations are diazoxide responsive, others are not. Failed medical treatment, unfortunately, necessitates surgery. And remember that congenital hyperinsulinism could be either isolated or syndromic, and the most famous is Beckwith-Widman. And finally, after reviewing various causes of hyperinsulinism, there's a very important question. Why is early diagnosis and management of neonatal hypoglycemia crucially important? The answer is there is severe neurological sequelae of hypoglycemia. We need to save this infant or neonate's brain. We need to avoid mental retardation, seizures, developmental delay, and personality changes. And therefore, early detection and management of hypoglycemia prevents serious neurological sequelae, which is very, very important. So my final thoughts on neonatal hypoglycemia are: screening and management of neonatal hypoglycemia is important. Early diagnosis and management avoids serious neurological sequelae. The critical sample is mandatory in non-responders. Most cases are transient. This is very fortunate, and they resolve spontaneously, but unfortunately, some are permanent and require aggressive and specific management. So we need to decide, is it a transient, is it the mild, or is it the severe case that will need the treatment? And finally, this is the blood sugar fairy. She says, I'm the blood sugar fairy. If you can see me, your blood sugar is too low. Thank you very much for your attention.